Great. So, good afternoon, everyone, and I'd like to thank Viraj again for this opportunity. So, so I have three cases. Let me see if I can cover them over the next 25 to 30 minutes. So, I'll start with some basic questions, and then we can take it from there. Any one of you can take them up, and feel free, anyone in the audience, if you want to have some questions. So, maybe I'll start with Dr. Aditi. What percentage of your patients with neuroendocrine, I understand that this is not your primary area of interest, but with that caveat, let's say out of 10 patients, how many come with localized disease as opposed to widely metastatic disease out of 10?
Maybe 1 or 2.
Okay, so predominantly they come with advanced disease.
Yeah.
Correct.
Any of the panelists who would like to offer a different opinion?
Sir, NED is already rare, but means out of 100 only 5 patients, not more than that. Usually they present as a metastatic state.
Okay, so a majority of patients are metastatic.
Shall I answer everything from my side? Then
Sure.
we can move over.
Please go ahead.
So that frees me for 10 minutes also. So usually means since I've seen 15-20 odd patients in last 2 to 3 years, one insuloma I diagnosed, and that was the only patient who was localized. So this is how it is. Chromogranin A, usually PPI does do hindrance, but that's the only way which we have.
So, do you use it or do you not?
Definitely you have to use it, because if it comes down, patient will be very calm, soothing, and everything will be there.
So, for non-medical patient-related reasons, chromogranin can be used. That's what you're saying.
maybe we can
Okay,
use.
fair enough. That's okay.
Usually DOTA-TET PAT is what we do until unless you are stuck in somewhere grade 2. Because grade 2 it is very difficult. That is probably grade 3 is easy. You give chemotherapy, something like that, and it's easy. Grade 2, you are always in a trouble. On
So
HPR,
again,
probably
the answer is that usually you want a DOTA, rarely FDG. Am I right?
Yes.
Fair. Okay.
On HPR, probably what guidelines say, maybe and mitotic index is important. Differentiation is plus minus, because that is an objective way probably.
So I'll ask the pathologist that, because we have a pathologist on board here. So in my head it's the MIB index, and okay, differentiation can take care of itself, and others have other opinions. For you, if I say what is more important of the two, is there something like that, or both are equally important? Let's say I have a well differentiated NET, but it's 35%. That doesn't make sense to me. But if it's, so your thoughts on that?
Particularly high-grade neuroendocrine tumor, we try to differentiate from grade 3 neuroendocrine tumor from neuroendocrine carcinoma.
Correct.
Because both have different molecular genesis, both treated differently. Carcinoma treated platinum-based therapy.
No, let's stick to NETs. I mean,
Yeah.
the grade 3 NET, which is largely, this side of the armamentarian, 30-40% MIB index.
We look at the morphology. We
Morphology.
look at if there is a classical area of grade 1, grade 2, we stick to the grade 3 neuroendocrine tumor. But
Okay.
if there is a appearance like nested appearance and carcinoma like, sometimes we take help of immunohistochemistry P53 and ATRX to
Yeah.
differentiate these two.
Yeah, and oftentimes we see multiple populations which some are well differentiated,
If
some are
there is
not.
Not well. If there is a well differentiated, it is easy to call it grade 3.
Okay.
But if it is not there, then we use
So, in
immunohistochemistry.
your opinion, morphology and MIB kind of go together. You have to look at both.
Yeah, definitely.
Okay,
Definitely.
great.
So, Anand,
Yes.
answer to most of these questions apart from the third one depends upon which center are you practicing and what is the backup team that you are available and how good you trust your pathologist and vice versa. So it depends upon center to center. If you are in a high volume center like yourself and Tata Memorial, the answers will differ from the one outside.
But in terms of patient presentation, I think we all see, I mean,
It's like
there
if
is
you end up
referral
seeing more
bias.
patients, you will end up seeing the localized entities also.
Okay,
As
that
simple
I
as
agree. Point number one, I completely take your point that, if you're a referral center, you probably see one type more. But I mean, the amount of time we were taught in teaching about functional NETs, they are really rare. That's my sense.
I agree, of course.
That's what I was trying to bring about, right? Okay, great. And the last point on the chromogranin, I've stopped doing it because of the number of variables in testing. And if 100 goes to 150, what do I do? So I don't use it as much, but yes, patients feel happy
It is a placebo tumor marker.
yeah, that's one way of putting it. Great. So
There was a
this
study
is
in US, Anand, just on that chromogranin.
Yeah.
I stopped using chromogranin since 5 years.
So normal population versus neuroendocrine patients population. Everybody got chromogranin test. Guess who had more chromogranin levels? Normal population. Yeah, so
Yeah.
it completely.
See, the point is, I have treating one 75-year-old male. He was getting treated. He's since last 8 odd years. He's just doing doctor shopping, but he's very happy if his chromogranin is low. He don't let me. I don't want him to advise a DOTA-PAT. So that's why I let it chromogranin A. If it is low, I am avoiding a DOTA-PAT.
No. See, I mean, there will be. No. Let's
But,
stop
if
that
it-
there in the
if
sense
it is
that.
elevated at baseline and patients is symptomatic benefit after the treatment, and CT scan is like 19% or you PET 21% increase, that is the more than the criteria of progression, then what will you do? That will do the chromogranin A. If it is reduced, then that patient is
No.
responding.
So this is a difference in philosophy of treatment where the symptoms and the scan versus a CGA. You know, what is more important to you, right? I think the CGA has too many variables and its levels in the normal population, they do not help me in a patient. So that's individual philosophy of treatment. Great. So this is the first case, right? This is I hope all of you can see it. This is a 66-year-old lady who was largely okay. She had gallstones. She said her pain was due to gallstones. Finally, she got evaluated. A CT showed an HOP mass, which was 2.5 centimeters. And she had liver lesions, but mainly on the left lobe, and a doubtful lesion in the right. A liver biopsy was done. It showed a MIB index of 7%, right? So that's the basic history. Any other detail that any of you would want, besides, of course, a scan, a DOTA? So what will you do next? Let's say you're in a center which has access to most things. I've given you 6 options. You can pick any of them. Dr. Mitanshu, maybe you can start.
So DOTA-PAT, we can go ahead considering the long history and indolent course of the disease. So DOTA-PAT will be enough, I think.
Okay. So in your head, is there a point when you say, I want both a DOTA and an FDG, or, a DOTA is enough?
Depending on the symptoms profile and the
The-
duration,
okay.
I can
So
judge.
your
and
symptom
depending
profile.
on the tumor burden and the number of METs, more burden of the disease, we can think of doing
Okay.
both the things.
So burden of disease and symptoms might push you to do a FDG PET also. Anyone else would want to do anything else on the panel?
For this patient, I think DOTA-PAT alone should
Yeah,
be good enough.
fair enough. So there are multiple cutoffs that people have suggested that, if a MIB is more than this, do a PET also. But I think these are artificial cutoffs. All of us would largely do a DOTA and take it from there. Fair enough. So these are the images, and surgeons love images. So I have some images. So there's HOP, and I can't show you the right lobe lesion, but predominantly you have an HOP mass with a very large left lobe lesion, right? It's a single lesion, not the initial report which says there were multiple lesions, right? And in case you just want to look at it again. So this is what you have on the DOTA. Options for treatment. And all of you can go one by one. And I'll put you on the spot and say you have to pick one.
No, start from the other end.
Okay, maybe. Yeah, he's done his job. He said it's a MIB grade 2, and 7%. Yeah. So
if the performance status is good,
I've given you all the details. His performance status, GSP is 0.
so if the surgeon thinks, then we go for the resection of primary and liver mets as she is symptomatic.
She's largely asymptomatic. Minimal right upper quadrant symptoms.
I think so. Resection will be the
Okay, resection of both.
both, sir.
Okay.
Debulking.
If possible, resection of both, otherwise resection of primary and TEA, TACE, whatever is.
Okay.
Or SBR.
Just remember that she's been with this for 5 years. Huh? I'm just saying. Dr. Tarachand? Huh?
हम दोनों जयपुर से एक साथ आए हैं, मेरे खिलाफ जाएंगे नहीं.
Okay. Dr. Amol?
No, we'll discuss with the patient, and if okay, go ahead with the surgery. Take it out.
Okay. I'm thinking you will guess surgery.
So now I'm in the spot, but I would like to look at the liver more carefully
Sure,
because
agree.
it should not be
Yeah.
an extended left.
Yeah, you would
it-
want
it
an
looks
FLR,
like a-
be
yeah.
very careful and then take call. Fair
Yeah.
enough. But largely the panel seems to be saying, let's go ahead and do the surgery. Am I right? Okay, great. So these are some of the older criteria, what they used to use for surgical management of NETs. The type 1s definitely would go for resection. Type 2s somewhere in between. Type 3s not. Right? This is not an all or none criteria, but this is what was used. And there is also that concept in NET that even if you don't get R0, 70 to 90%, if you're able to remove, you've done a good job, and that is an option you can use.
That
Great.
is, for the number of metastases. When you have one large lesion, I
sure.
think in
What
this
I'm
you
saying
have
is,
to.
even if you get most of it out, you're still doing well, right? But this patient, said, she thought like me. She said, I've had this for 5 years. This might be a morbid surgery. I don't want surgery. Now what do you want to do? And maybe we'll start from Dr. Aditi this time. Patient says, no surgery.
So, in a tumor that's been there for 5 years, first of all, we don't know that whether it's been growing or not. We don't have any reference imaging, but we assume that it's not growing too much. There's no harm in putting the patient on short-term observation and, revisiting it in 3 months, or
Sure.
let the medical oncologist put the ball in the medical oncologist.
The medical oncologist is next to you.
So what is the DOTA scan finding?
The
We have done
DOTA
the scan, we have not told us the finding. Oh, that's the only localized thing.
Yeah,
That's
it is
that's
the pancreas and the left
If
lobe
she
of
doesn't want
liver.
surgery, observe.
Okay,
From my side.
observation. Great. Dr. Tarachan?
Yes, observation.
Okay.
She doesn't want surgery or surgeon don't want to
No,
operate.
no,
That's
she
the
doesn't
question.
want. She doesn't want.
Then probably observation. No, ma'am is telling no, we cannot do it.
Wait. Mitanshu? Okay, go with the. Okay. I actually would have thought that.
See, I will counterpoint means he will tell LAR. But the point is, if the patient wants surgery or you want to give something, give chemotherapy. It will reduce the size. You can operate later on.
For
That is
this
also which
patient-
we can do.
Okay, so.
LAR will not decrease the size. Will never.
Sorry? So,
LAR will not decrease the size.
okay,
That's the
so-
point.
Okay, so let me get this right. In case she doesn't want surgery, but she's okay with treatment, you will think of chemo. No, in case.
If she wants surgery, then probably we can go for chemo or else observation because there is no symptoms for now.
Okay, so I actually think LAR has some anti-proliferative action as well. Observation would be my first option also, but if they want some kind of in-between option, I think monthly LAR is well tolerated. We'll keep it in check for a while. I don't know how long.
So, like you said, chromogranin is a placebo test. The
You can do
LAR
that
is
here,
a
yeah.
placebo treatment for this patient.
No. So no.
This
no,
patient,
no, no,
I'm
no.
saying MIB index of 7%. This
Okay,
patient.
let's agree to disagree on this. I don't think it's placebo, but okay, fair enough. So this lady actually took LAR and she's been on it for 2 years, doing largely well. So the whole idea of bringing this case was that NET is not wholly guideline dependent. There are multiple right options is what I was trying to bring. You could observe, you could give LAR, you could resect as well. That's
So basically the same thing has happened. No? Nothing has changed in the DOTA scan after giving LAR. As per
no,
you
some
only.
decrease in metabolism. I
Some
wrote that.
decrease in metabolism.
Yeah, but I agree with you. You're not looking at a large decrease in size. That is a fair point. Fair enough. Okay. So, just for discussion's sake, assuming the patient had secretory symptoms and did not want surgery, then would you think differently? Then I think all of us would agree to
Severity
LAR.
of symptoms, short-acting LAR, short-acting octreotide followed by LAR. That's
Okay, for immediate control and then shift along. Okay, fair enough. Yeah. Just to point out that for secretory symptoms, TAE to the liver is actually a very good option. It gives very good control of symptoms. So, but yes, most of us would go with LAR. Fair enough.
I have one question
Yeah.
for the panel. You are assuming that this patient has refused surgery and will never agree to surgery. But what if she changes her mind? Then in that scenario, would you change your choice of treatment?
Of course, the moment she says yes for surgery, refer to surgeon.
No,
Get it operated.
I mean, does your choice of therapy in
That's a good question. Let's say that she wanted to defer surgery for 6 months, for example, right? So this is potentially resectable. And if you are giving LAR, it will stabilize. I don't think a more aggressive approach will help you in your surgery later. May or may not.
But at least you would not observe.
Yeah, fair
Because you
enough.
still have risk of progression.
Exactly. Okay, some basic questions again. In grade 2 or grade 1 JEP-NETs, I've just made it gastroenteric plus pancreatic. Do you ever prefer upfront PRRT compared to LAR? Anyone? I mean, you can answer all 3 questions, Dr. Amol, and then I can go forward.
So for grade 1, grade 2, no, I will still be happy with LAR as compared to PRRT.
Let's say the MIB index is 14%.
I will still discuss, but if you ask my comfort, I am still comfortable with the LAR in
Okay.
grade 1, grade 2.
Fair. Grade 1, I think, is a given.
Grade 2 also 14% MIB index, not much symptoms.
Okay, great. I'll come to that. Tarachand?
Yeah, usually I prefer LAR, but if the patient is symptomatic and disease high burden, then usually I use a PRRT along with the LAR.
Okay, so you will use a symptom-based approach more and not a one for all.
Always, yeah.
Fair enough. Okay.
Also from Jaipur.
So, okay, also from Jaipur. Yeah, you guys should have sat differently. Okay, Dr. Mitanshu?
Sir, LAR will be preferred choice in this
Okay.
case.
The reason I'm saying this, and this is not an absolute, is that both the Clarinet and PROMET trials, which are the seminal trials with LAR, took patients with a MIB of less than 10. Okay? So that does not mean that LAR will not be active in hugely SSTR expressing lesions, but purely from a guideline point of view, maybe you want to consider PRRT more. That's the point I was trying to bring about. And just as a question, let's say you had someone with a grade 2 NET, and on whatever therapy, they had disease progression. Do you do a rebiopsy or do you just sequence?
If patient progress on available therapy, then probably dual PET,
Yes, correct?
then
And-
probably dual PET, along with the biopsy from the most active area,
yeah.
and then probably will. If
So
there's
would-
no active area, then probably we will.
Would all of you kind of think similarly that,
He's from Jaipur.
yeah,
No, if it is feasible to do it, one may consider, especially you are used multiple lines, it's progressing. It should not, with a clear intent of you're not missing out some different pathology that may be happening, metachronis or something else. So patient to patient it will vary, not necessarily always.
always, fair enough. Because see, a grade 1 of a MIB of well differentiated of 2% is not going to become 30%. That's unlikely, right? But something which
Anant
is,
was- I think
yeah.
if a patient is having high burden disease or symptomatic, then NATR2 is also the answer. No?
I'm coming to that. That's the whole idea. So,
right now I'm treating a patient, MIB of 7-8 for last 5 years. Now suddenly Krukenberg, increase in liver mets, biopsy 35%.
from 5%?
From 8%, yeah.
Okay, so
And now we did PET again, so PET is also showing little uptake. Of course, DOTA is still 100, 120 SUV, but and at least in my practice, I've seen at least 4 to 5
Yeah.
changing aggressive.
So I guess
So I've started doing biopsies
yeah.
now. If
I
there is
guess
a
that's
sudden
why-
change in the course.
That's why we have the Gaussian bell curves, to remind us of this, the extremes. But my point I was trying to make was largely 4 to 5% going to that much would be odd, but fair point. We can think of a biopsy. It does help us once in a while is what I was trying to say. Great. So this is the second one. We have 10 minutes. This is a 55-year-old lady who was definitely more symptomatic than the earlier lady. She had significant pain. She had symptoms of facial flushing. She saw Viraj and he immediately said, "This is NET." Yeah. So she So since we are in Ahmedabad, and so she underwent a liver biopsy, and this time it was a different report. It was a grade 2 NET with a MIB of 12%. The differentiation was unclear, and the dual PET actually showed significant uptake, right? And this is a net PET score of 3, which means there is some degree of FDG uptake also, as opposed to only SSTR expression. So that's the scenario. Again, we have some scans here. It was predominantly liver disease. They were not able to identify a primary, but which is what happens a lot of time. So this is the basic scan. And so, assuming there are no fitness issues, no logistic issues, what will your NET related treatment plan be? Maybe we can start from anywhere. And the guys from Jaipur have to give separate answers.
He stays in Jaipur.
So anyone.
Patient is having a SSTR uptake also and FDG uptake also.
Yes, yes.
And grade 2 disease with the symptoms. So I will go with option 5, PRRT plus captemozolomide.
Okay, fair enough. Anyone else?
Before we should stabilize the symptoms of whatever she is
Yes,
having.
let's say we'll give her short course for
Whatever,
yeah.
long course, short course.
Yeah.
maybe
But overall, what will your treatment plan involve?
both has to be given.
You're going to give chemo and PRRT. Dr. Mitanshu? And then Dr. Amol. I'll just, this is the biopsy, right? And she's definitely symptomatic. You need to do something here. And if you want to do something else, that option is also there. Okay, carbo etopo in this, you would largely reserve that for NECs who are having a higher grade index and those who have significantly more FDG PET intake. I don't think it would be an upfront option here.
Usually carbo, eto or platin based regimen works when Ki is more than 50. Here it is 12. So then probably kept, but one thing is there, what about MGMT? Is anybody doing MGMT in NET?
Oh, okay. So, I'm not, but the data is there, yes. Dr. Amol, you have not answered. One option of treatment.
PRRT.
Only PRRT?
Yes.
Okay, great.
Captem.
Only Captem?
Only Captem.
Interesting. Okay.
PS1, no? You said
Huh?
PS1.
PS1, yeah. Okay. So, this is...
In PenNet's upfront PRRT, the data is still emerging.
No, I think, so I'll just quickly run through these two studies because it was referred to. One is the NETTER2, which says that, PRRT is definitely better than high dose LAR. And this is the ECOG-ACRIN study on which Viraj wants to give chemo. So both these studies had a significant number of pancreatic NETs. So I think the option of PRRT alone is a fair option. But what a lot of centers, and this is coming mainly from Australia, is that the moment you have significant PET expression, FDG expression, they feel that only PRRT is not enough. So they are combining.
I'm saying you monitor, you see what happens to them. You
So
do it,
what
repeat
they
scans
do-
after 3
yeah.
months, then take a
What they do is they give PRRT sandwiched with Captem, and that is something they have been propagating for a while. But I agree with you that purely if you go from a data point of view, PRRT alone will also suffice. I think that's a fair approach.
Because this patient will behave very badly.
Yes, that is something we need to consider. But Viraj, I would definitely include PRRT in the treatment paradigm.
Yeah, of course, the patient will get PRRT sometime in their lifetime, but it's just not day one.
Great. So this patient actually got 2 sessions of PRRT, didn't do as well. And those are the images. Actually, when I saw it, it looked okay to me that it has come down, but my nuclear medicine person said, no, it was suboptimal response. So we've gone with the guideline dependent option. Given 2 sessions of PRRT, symptoms are iffy, not great benefit. Scan also is iffy. What next?
The next option, Captem.
Anyone else? All of you would give Captem? Yeah. So I've given you some options here. What we did was we actually gave intra-arterial PRRT. There is emerging data for this. There is small phase 2 data also. And that actually helped more. But I completely agree with all your points that this would have been a good time maybe to think of a rebiopsy also, because not responding at all to PRRT is a little worrisome and we need to think beyond the guideline. And probably giving chemo would have been options, but we gave intra-arterial PRRT, and that actually you can clearly see that there was a really good response. And this is a good trial for any of you interested. Very small data where they compared different lobes of the liver and saw how intra-arterial PRRT worked or not. So
How long the response was maintained
no, so
after you got the response?
So this patient actually was put on cape time after that. Despite the response, we thought that biology wasn't good. So
That's what my point
Yeah,
is.
I think-
That only giving intra-arterial
Yeah.
may not be helpful.
may
you
not
have to
be,
give
yes.
systemic.
Yeah, agreed. Point taken. So I'll just touch upon grade 3 JEPNETs. Do you always do a DOTA? Do you only do FDG? What do you do? Anyone?
Unfortunately, they come with some of the other imaging already
Okay.
from outside.
So then,
If you are
do
in a
you
tertiary
insist
center.
on both? If they've come with one, will you do the other in a biopsy proven? He says, your pathologist has said 30% MIB index, not well differentiated. What will
So
you
if
do?
the biopsy is clear, I don't think so. Another imaging is required. If
So
you have the
if-
one good imaging,
So if they come to you with an FDG, you will be happy with FDG alone. You will not do a different imaging. Is that right?
probably yes.
You will not do it.
I will
Okay.
not do it.
Tarachand?
It is a poorly differentiated according to the grade 3 and MIB index is low. Then
It's
in that
30%.
case, Huh?
It's 35%.
then I think not needed separate imaging, and I think that
You
is
would be
okay.
happy with an FDG? So this is one
As
of
long as it is not a carcinoma, I always order DOTA.
So in our heads, I think we pay a lot of importance to the MIB index. It is highly heterogeneous, and the ENETS clearly says that. And the closer it is to 20,
So that's what I said. If you have convinced with the histopathology report and you're trusting that,
But not
then
MIB,
you need not have
carcinoma.
both the
so
imaging.
even
So
if
it's all depend upon the
No,
pathologist.
no. Let's say this is not a well differentiated NET, okay, for discussion purpose, and the MIB is 30-35. The closer you are to 20% ish, there is no harm, and actually would be beneficial to do a DOTA scan as well, because some of these patients are SSTR's expression. The 20% cutoff is not sacrosanct. There are a number of patients who are SSTR expressing, and they might benefit with dual modalities of therapy as opposed to only chemo. That's the point.
The percentage in the data. How many, suppose you do it for 10 people, you will get for
I-
one,
No. I don't have those numbers. The numbers
Viraj?
needed to treat.
No, but I have 3 patients.
35% MIB index,
No,
grade 3,
50%.
undifferentiated, poorly differentiated, you do both the scans.
So the-
How much DOTA uptake you will get in 1 out of 10?
No, it's
We
more
don't
than
have
that,
that
but I
number.
don't have the exact numbers.
But they
So it cannot be more than 2 out of 10.
But they do
20%.
benefit.
You have
just
a
one-
treatment option, right?
They do benefit.
So of course, if the patient affords
STR
everything, you can do
blockade.
everything.
No. I'm assuming that we have treatment options. It gives us one more option. Because otherwise you will only have essentially
You know,
cape 10
etocarbo,
and then
that's
cisplatin based treatment.
With that, if you do 2 scans with hoping that 20% will pick up something, for the monitoring it becomes difficult, because again after 3 months, then are you going to repeat both the scans or not? Patients gets confused, you get confused. That is where I prefer to stick to one, especially in a such situation when the MIB is already 35, poorly differentiated.
Fair
Sir,
enough.
I'd just like to come. Sir, talking about your Amol sir, if you have FDG PET report and you have high-grade tumor, apparently on pathology, I've seen one case, means it was very atypical spinal involvement, and it had gone to multiple centers, and if you don't do both the PETs, means you are likely, if a very high-grade tumor is there, you can have a high uptake with PET CT or FDG PET also, and along with that DOTA PET. So when you are treating, you have to follow up the patient. You have to take a decision about giving LAR. And do you mean to say that you will not give LAR to this patient?
No, so I think I'll just answer that. A patient who has significant FDG uptake with a high grade NET, largely LAR would not be part of the plan. Largely.
No, sir, but just I had a patient who had high-grade NET, very high-grade NET, very rapidly proliferating. It was metastatic, and I did both the PETs. Both had good uptake, and it responded to LAR.
Only LAR?
No, initially I had to give chemotherapy.
Yeah.
But
So this is
subsequently, she responded to LAR also, and she was a very morbid patient.
Did she respond to chemo or not?
Yes, she responded.
So after she responded to chemo, you consolidated it with or maintained it with the LAR.
and
That's
this
what
is
you're saying.
largely an
That's a
exception.
different story.
Sir, but it becomes, see, if we are monitoring a patient, we have to have the complete picture of the disease. It is not that I can just go with FDG PET and not do a DOTA PET. It is incomplete picture.
So I think
The whole
we'll,
point is
no,
that
no.
if you do both at baseline, then you have to keep on doing everything at the repeated, whenever you repeat the imaging after 3 months, 6 months, both.
The point that
there
we
is no
need
end
to,
to that.
yeah, the point we need to do is, I think it's better to have all the information up front. We can follow up based on what the upfront, scans tell us. If the DOTA is not useful at baseline, we're never going to use it again. But if it is, then I think we should use it for follow-up as well. That's the point I was trying to make. With that, I think I'd like to thank all the panelists, and especially Dr. Aditi and Amol sir, who joined in at the last moment. Thank you so much.
Thank you.